When your stomach does not empty after pancreatic cancer diagnosis, what are the choices? Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about has been told about gastric outlet obstruction, maybe from pancreatic cancer or another condition, and you're trying to understand whether a stent or surgery is the better option, you're in the right place. I know when you're facing this diagnosis and hearing about procedures you've never heard of before, it can feel overwhelming. Today we're going to break down exactly what gastric outlet obstruction is, why it happens, and most importantly, what the research actually shows about your treatment options. By the end, you'll understand the real differences between endoscopic stenting and surgical bypass, and you'll know exactly what questions to ask your medical team. Gastric outlet obstruction means something is blocking the area where your stomach empties into your small intestine, specifically the duodenum, which is that first part of your small intestine. When this pathway gets blocked, food and fluids can't move through normally, which leads to some pretty distressing symptoms. Stents work by propping open that blocked area from the inside, while surgery creates a detour around the blockage entirely. Research shows that gastric outlet obstruction develops in about 15 to 20% of patients with pancreatic cancer, though it's typically not present when they're first diagnosed. If you've been diagnosed with pancreatic cancer, you're looking at roughly a 1 in 6 chance of developing this complication at some point. The symptoms are pretty distinctive. You will experience early satiety, which means feeling full after just a few bites. The symptoms include early satiety, which means feeling full after just a few bites, along with nausea, vomiting after meals, and significant weight loss. These aren't vague symptoms, they seriously impact your quality of life and your ability to maintain nutrition during cancer treatment. This X-ray study demonstrates how the barium contrast sits in an enlarged obstructed stomach and does not progress to small bowel. The two main treatment options are endoscopic duodenal stenting, where a flexible metal tube is placed through a scope to hold open the blocked area, and surgical gastrojejunostomy, which creates a new connection between your stomach and small intestine, bypassing the obstruction entirely. You can observe the endoscopic stenting in Figure A and surgical bypass in Figure B. A Dutch multi-center trial called the SUSTENT study directly compared these approaches, and the results revealed important trade-offs. Endoscopic stent placement provided faster initial symptom relief, patients felt better quicker. But here's the catch: stented patients had higher rates of major complications, recurrent symptoms, and needed more repeat procedures. Long-term relief was more likely after surgical bypass. The median duration of stent patency, meaning how long the stent stays open and functional, is approximately 6 months. If you're supporting someone through this decision, this timeline matters enormously. 6 months of relief might be perfect for someone with advanced disease and limited life expectancy, but could mean multiple repeat procedures for someone with more favorable prognosis. For many patients with symptomatic gastric outlet obstruction who are not candidates for cancer resection, particularly those with advanced disease, poor performance status, and short life expectancy of 2 to 6 months, endoscopically placed expandable metal stents are generally preferred over surgical gastrojejunostomy. What does poor performance status actually mean? We're talking about patients who struggle with basic daily activities, who are weak from their disease, who couldn't easily tolerate a major operation. For these individuals, the minimally invasive nature of stent placement done through endoscopy without cutting is a significant advantage. The procedure can often be performed in under an hour, and patients typically recover within days rather than weeks. When unresectable disease is discovered during operative exploration for other reasons, current practice is to routinely perform a posterior retrocolic gastrojejunostomy. That's a specific type of bypass whenever biliary bypass is being done, regardless of whether gastric outlet obstruction symptoms are present. This is prophylactic, meaning preventative. A meta-analysis of 3 prospective trials examined prophylactic gastrojejunostomy, creating the bypass before obstruction develops in patients having biliary bypass for unresectable pancreatic cancer. The results were striking. Patients who had prophylactic bypass had dramatically lower risk of developing gastric outlet obstruction during follow-up, with an odds ratio of 0.06. You can do the math right, that's about 94% reduction in risk. Rates of postoperative complications, including delayed gastric emptying and mortality, were higher with the prophylactic approach. However, the average hospital stay was 3 days longer. This matters for quality of life calculations and healthcare costs. The real benefit has been questioned because an open surgical procedure to treat biliary or gastric obstruction isn't actually needed in the vast majority, 98%, in one report of patients with unresectable pancreatic cancer. Up to 60% of patients with pancreatic cancer have slowed gastric emptying without any evidence of actual tumor blocking the duodenum. Think about that: more than half of patients. The likely explanation is tumor infiltration into the nerve plexuses, the networks of nerves around the pancreas that control gut movement. This delayed emptying leads to loss of appetite, and in about 1/3 of patients, nausea and vomiting. A gastrojejunostomy bypass is completely ineffective in relieving symptoms in these patients. Because the problem isn't a physical blockage you can bypass, it's a nerve and motility problem. The diagnosis can be made with a gastric emptying study, a nuclear medicine test that tracks how your stomach empties, or as a diagnosis of exclusion when imaging rules out mechanical obstruction. Unfortunately, the symptoms from delayed gastric emptying are often difficult to control, although prokinetic agents like metoclopramide can help. Metoclopramide helps your stomach contract more effectively to push food through. If you're facing persistent vomiting from this, there are practical interventions available. Decompression using a venting percutaneous endoscopic gastrostomy tube, we call it a PEG tube, can be more comfortable than a nasogastric tube that goes through your nose. Combined venting and feeding tubes can both relieve nausea and vomiting, while providing nutritional support during chemotherapy by feeding into the small intestine beyond the area of poor motility. Endoscopic duodenal stenting is successful in the majority of cases when we're talking about immediate technical success, getting the stent in place and open. But success isn't just about the procedure itself. One study tracking patients with biliary and duodenal stents found the median time to a stent-related event was 4.4 months. Events included stent blockage, need for repeat procedures, or migration of the stent. Surgical gastrojejunostomy, when performed in debilitated cancer patients, carries its own risks. In one report, postoperative mortality was 3.1%, and perioperative complication rates were 22%, with a median survival of 6.5 months. These aren't trivial numbers. We're talking about roughly 1 in 30 patients not surviving the surgery, and more than 1 in 5 experiencing complications. The decision isn't just medical, it's deeply personal, and depends on what you value. Faster initial relief versus longer-lasting solution. Avoiding surgery versus avoiding repeat procedures. Quality of remaining life versus length of hospital stay. Some patients prioritize being home quickly, even if it means a higher chance of needing another procedure later. Others prefer the durability of surgery, despite the tougher initial recovery. You need clarity on your specific situation. Ask, what is my estimated life expectancy with my current disease status? This isn't morbid, it's essential for making the right choice. A 2-month prognosis points strongly towards stenting. A 2-year prognosis changes the calculation entirely. What is my performance status, and am I a candidate for surgery? Request specific information about how they're assessing this. Can you care for yourself? Are you spending most of the day in bed? Can you do light activities? Is my obstruction mechanical from tumor, or could this be delayed gastric emptying? Ask whether a gastric emptying study has been considered, because this fundamentally changes the treatment approach. If I choose stenting, what's the likelihood I'll need repeat procedures, and what does that involve? You need the specific numbers for your center, not just general statistics. If I choose surgery, what are your institution's specific complication rates? Centers with high volumes of pancreatic surgery generally have better outcomes. If you have a stent and develop fever with abdominal pain, this could indicate stent-related infection or perforation. Call your gastroenterologist or go to emergency department immediately. If you cannot keep down any liquids for more than 24 hours, you're at risk for severe dehydration and electrolyte imbalances that require hospital evaluation. If you've had surgical bypass and developed sudden severe abdominal pain different from your usual discomfort, this could indicate complications like bowel obstruction or an anastomotic leak. Even with treatment, you'll need strategies to optimize your nutrition and comfort. Eat small, frequent meals rather than 3 large meals. Think 6 small portions throughout the day, each about the size of your fist. Choose foods that are easier to digest: well-cooked vegetables, lean proteins like fish or chicken, and avoid heavy fatty foods that delay gastric emptying further. Stay upright for at least 30 minutes after eating to use gravity to help food move through. With stent placement, you should be able to tolerate liquids within 24 to 48 hours and advance to soft foods within several days. With surgical bypass, recovery typically takes 2 to 3 weeks before you're eating comfortably, though improvement should be progressive. If symptoms aren't improving on this timeline, contact your medical team. This could indicate a problem with the procedure or that delayed gastric emptying is the underlying issue. If you're supporting someone who cannot eat, understand that combined gastrostomy-jejunostomy tubes can both decompress the stomach to relieve nausea while feeding into the small intestine to maintain nutrition during cancer treatment. This is strongly preferred over total parenteral nutrition intravenous feeding because it maintains gut function, has lower infection risk, and generally allows better quality of life. How will we monitor whether the stent is working? Typically through your ability to eat and symptom relief, but sometimes repeat imaging. If I need a repeat procedure, what does that involve? Usually another endoscopy to place a stent within the blocked stent or to remove and replace it. What are signs my surgical bypass isn't working properly? Persistent vomiting, inability to advance diet, or severe abdominal pain should prompt reevaluation. The choice between endoscopic stenting and surgical bypass for gastric outlet obstruction depends critically on your disease stage, overall health, and life expectancy. Work closely with your multidisciplinary team to individualize this decision. Your next steps: schedule a detailed discussion with both your gastroenterologist and surgeon to review your specific situation using the questions outlined above. This information is for education. Always discuss your individual situation with your healthcare provider. I have outlined several reputable resources here which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.